morning, everyone. Thank you very much for the invitation to Professor Guiseppe and the organizing committee. It's a great conference. My name is Giuseppe Catanuto. I work in Italy, in Catania. I'm an oncoplastic breast surgeon, and I'm also the executive chairman of Fondazione Greta. You probably know this name. Can you hear me well? Okay. I want to start my presentation talking about the terminology, conservative mastectomies, because I think that we used this terminology for the first time in the modern year in 2009 when we presented a paper that was a narrative review on several top journals, and this paper was every time rejected, and the rejection basically was based on this. They were saying that this was a paradoxical term that could be misleading and inappropriate, warning that the potential readership would associate it with retention of breast parenchyma, and was rejected several times. At the end, was published on a Journal of Plastic Surgery and Aesthetic Plastic Surgery in 2009. And eventually, a few years ago, it was 2009, then in 2012, the same terminology, conservative mastectomy, was accepted as a narrative review on the Lancet Oncology, was written by Professor Veronesi, and we know that the reviewer was the same reviewer of ours. So probably during the terms was even more accepted. But this is not a new term. And basically, you know, we are Italian, so we like, playing with words. And conservative mastectomy basically is an oxymoron. So it's a figure of speech that combines contradictory terms. And it's often used to call the attention. And this is one of the most famous cases. Is in the Romeo and Juliet from Shakespeare, how heavy lightness, serious vanity, is just to call the attention to the contradiction. But conservative mastectomies is not a new terminology. There is a heavy historical background in the past. If we go back to 1953, there is a very interesting paper that comes from a lecture from the Royal College of Surgeons that was talking about the conservative method, and saying that there is nothing new about the conservative treatment of carcinoma of the breast, which was first conceived by Keynes in 1927, so about 1 century ago, in a paper that was published 70 years ago. And what we understood from these historical papers is that the terminology, conservative and mastectomy, was associated in a way with some kind of anatomical preservation of the thoracomammary area. So if, for instance, you preserve the axillary lymph node, if you preserve the muscle, that was considered a conservative approach. And you can see this other very interesting paper from published in 1962, so 60 years ago, that was comparing radical mastectomy with the conservative group that was including simple mastectomies and tumor excision. It was 1962. And eventually, you can see, when looking at crude survival rates of patients with operable breast cancer, in 1962, we already knew that survival was more or less equivalent. Obviously, we were before this era of historical trials of breast conservation, but the idea was already present, and the terminology was mainly associated to the degree of preservation you did on the anatomical area of the thoracomammary area. Now, what is the reason why we started thinking about conservative mastectomies? By the late 80s and 90s, when you had the diagnosis of breast cancer, there were two chances. If you had a small unicentric cancer, you can have breast conserving surgery. But if you have large and multicentric, irrespective of tumor stage, that means even in early stage breast cancer, a mastectomy was an unavoidable choice. So this kind of dichotomy posed a lot of questions. By the time, at the beginning of year 2000, patients were more aware, cosmetic results, there was more request for breast conservation. We started using oncoplastic mammoplasties, also oncoplastic surgery, and there was starting some kind of reasonable evidence that breast conserving surgery was safe even in the setting of multifocal and multicentric breast cancer. So what to do with patients with poor tumor to breast ratio, with patients with multicentric breast cancer, but still early stage breast cancer? Why giving this patient a mastectomy? And we started hypothesizing conservative mastectomies in a way that it was conservation of the breast envelope, including the nipple areola complex. And the theory was that if you remove with a knife the entire glandular tissue, you are in a way imitating, simulating what the radiotherapy does in the setting of breast conservation. Because when you do breast conservation, you preserve the gland, you preserve the nipple areola complex, but you give radiotherapy. In this case, the ablation is done by the knife, by the surgical removal of the entire gland. Now, the question was, are we leaving residual glandular tissue behind? First question. And the second question was, is residual glandular tissue behind able to generate new cancers, or maybe generate a recurrence in case you leave cancerous cells behind? Now, if we go back to literature, there is this very interesting systematic review done also by some of the speakers, like Maria Joao, who is here in this hall, and Professor Portmans. It was very interesting because it was looking not only at histology, residual tissue in histology, but also at MRI. And well, if you look at the data, the single reports, you can see that literature is highly heterogeneous, and residual glandular tissue, for instance, at MRI, which is a very interesting tool that you can use to identify residual tissue, it can be up to 100%, even in the setting of standard mastectomies. So when you do a mastectomy, irrespective of the technique you are going to use, there is a very high chance you leave residual tissue. This is for sure. And you can see how heterogeneous is the literature, because we have very different studies with very different populations, with very different techniques, and obviously very different outcomes, ranging in MRI from 80%, from 20% to 100%. More or less the same results they had on sometimes, okay, it's not possible to see one slide, I don't know why. It skips one slide, but no problems. Anyway, residual glandular tissue does exist. It is possible to see it either on the MRI and on histology. And there is another very interesting systematic review. This is a Cochrane review, and it's done with very high quality methodology. And you know that the foundation, the Greta Foundation, is highly involved with Cochrane. We are doing systematic reviews. It's very high quality work. And you can see that the level of evidence is very low. There are no randomized trials that can solve all these questions. We can have only observational studies, including a huge proportion of patients, mainly done on the therapeutic setting, which is a completely different setting, because you know that we are on the therapeutic setting, we are likely to use further treatments. So there is not only the surgical treatment or maybe local regional treatment with radiotherapy, but there is also systemic treatment that has an impact on the control. And you can see from this systematic review that there could be also some kind of contradiction due to the low quality of evidence that we have. And for instance, in the comparison between nipple-sparing mastectomy and modified radical mastectomy, nipple-sparing mastectomies performed better than modified radical mastectomies in local control. And this is kind of a paradox. It is an obvious paradox. And why this happens? Basically, because the quality of evidence we are analyzing is very low, and we have a lot of bias, a lot of, in terms of the staging of the disease, in terms of the treatment the patient they had, the era in when patients have been treated with different kind of drugs in the systemic, in the adjuvant setting. But once again, it is reassuring to see that there were no differences in terms of overall survival. Our patients are safe if we do a conservative mastectomy compared to a modified radical mastectomy or any other kind of more aggressive technique. And this plot is very interesting. You see all the red dots that are demonstrating that the level of evidence, the quality of the evidence is very low. There is a lot of bias, selection bias, no randomization, but also significant differences between the compared groups for again, baseline characteristics and age, stage, and so on. There are some other meta-analyses. This is the one from Sophocles Lanitis, which is comparing different degrees of conservation of the breast envelope, skin sparing versus nipple sparing. But again, no differences in local recurrence between the skin sparing mastectomy and the nipple sparing mastectomy. So basically, the technique is safe. I don't know why it skips some slides sometimes. This is taken from another review from Jenny Rasby. And one of the most interesting aspects of this review comparing nipple-sparing mastectomy and skin-sparing mastectomy is that you have more complication in the nipple-sparing setting, which is probably something that makes the difference between a simple mastectomy, an increasing amount of preservation of the breast envelope. When you save the nipple, especially in the setting of large amptotic breast, you have a higher risk of complication. And this can reflect in some ways in the time from surgical treatment to adjuvant treatment, and can be compromising. And you can see that the rate is up to 15%, and the complication rate, the overall complication rate was 22.6% versus 14% in the skin-sparing mastectomy setting. Obviously, there are several attempts of expanding the indications of conservative mastectomies, even in the setting of more advanced cancer after primary systemic treatment. We may say that in most of these cases, everything is going well, more or less. If you have good response to neoadjuvant primary systemic treatment, at the end, local control and survival are reasonable, are quite good. Anyway, even in this case, we have very low level of evidence and no control groups, which is a substantial bias in the observation we do. And this is a review that we performed a couple of years ago with the team of Greta that was looking at nipple-sparing mastectomies in the setting, in the prophylactic setting. And once again, with a reasonable time of follow-up, no new cancers when you leave the nipple areola complex. So in the end, the technique seems safe. We have low level of evidence, but probably it's too late to plan a trial comparing modified radical mastectomy with standard, with nipple sparing and skin sparing mastectomies. What to do in this case? Well, we should rely on observational studies. But when we plan observational studies, we have to design it in a very reliable way. We have to standardize the outcomes assessment. We have to standardize the features that we consider before planning for a conservative mastectomy or a nipple-sparing mastectomy. This is very important because if the level of evidence is low and if the outcomes cannot be assessed in a standard way, we are not going to get any reliable information. So the idea is to create registries like the INSPIRE registry or the Italian registry done by Lorenzo Orzalesi. If you collect in this way a huge amount of data with standardized outcome, you will be able to perform the technique. I close here my presentation, and I'm really thankful for the invitation because I work in this brand new breast unit in Italy, in southern Italy, in Sicily, which is a small island in the Mediterranean. It's a brand new breast unit with very high quality, with JCI certification, breast center certification, USOMA certification, and is part of the European Commission initiative of breast cancer. I really invite you from the other side of the Mediterranean to come and visit us, and for sure we are very keen to come to Egypt and visit your institution to get to put together all our efforts and create an international network across the Mediterranean. Thank you for your attention.
We have the time for one or two questions. Yes.
Thank you very much, Dr. Catanuto. If you have a case with multifocal breast cancer, two cancers in two quadrants, would you prefer extreme oncoplastic procedures or conservative mastectomy?
Thank you very much. So, in the decision-making process, you have to assess, first of all, patients' preferences and values, and discuss the pros and the cons of both techniques, okay? Because if you can have a patient in front of you that doesn't need any kind of conservative mastectomy treatment. She may say, okay, doctor, I want my mastectomy, my simple mastectomy scar, and that's it. If the patient is properly informed, if she had a very good information process, that means using decision aids, using consultation with breast care nurses, and so on. We are happy with this. We can do a very simple case with very low complication rate. Otherwise, as a surgeon, personally, I always prefer breast conservation, just because, in my opinion, breast conservation is the better way to reconstruct the breast. Is the best reconstruction
Breast
technique.
conservation, you mean extreme oncoplastic?
Of course, yes.
Okay.
I mean, it also depends on the volume of the breast and on the characteristics of the breast. If it's a fatty breast, I mean, it depends on the size, on the location, on the size of the breast, and so on the ptosis. But as a surgeon, again, I always prefer breast conserving surgery, because once again, in my opinion, is the best way to perform autologous breast reconstruction.
Okay, I have a note and a question. First of all, I have to give you all the credit, about Greta Oncoplasty, that you were the first to describe the conservative mastectomy, and I personally witnessed this, and I was telling all my colleagues here that it all started with you, with the term conservative mastectomy. So this is a credit that
Thank you very much.
Everyone should know. My question would be, do you think that one of the advantages of conservative mastectomy compared to breast conserving surgery is to avoid the postoperative radiotherapy, or this is not one of the things that we counsel the patient about?
This is a very interesting question, because nowadays there is some kind of information that tells that when you do breast conservation plus radiotherapy, you can have an advantage in survival. Even in this case, this information is not derived from randomized controlled trials, and there is a lot of bias in these publications. Obviously, well, maybe a few years ago, I might have said, yes, you avoid radiotherapy, but probably nowadays, it is a very difficult decision. But certainly, well, it is something that we need to think about, and the potential advantage in survival is not sure, is something that we need to discuss.
Yeah, because
I still prefer, sorry,
Yeah,
I still prefer breast conservation with radiotherapy.
Yes, because what is surprising that we are in the era of de-escalation of treatment for breast cancer, but at the same time, you can see, as you mentioned, the indications of post-operative radiotherapy is increasing after the Lancet publication, the meta-analysis of 1 to 3 positive lymph nodes.
Okay.
They should receive radiotherapy, and it has an impact on survival. So this is why we are asking, because this is part of our counseling, that you are explaining the pros and cons of everything. And we always say that with the mastectomy, you may avoid the radiotherapy.
I'm not sure I'm going to counsel to do a counseling to my patient in this way. It's not a good indication. I think I'm not happy to tell my patient you are going to skip radiotherapy, unless obviously there could be some problems in getting radiotherapy because of the facility and so on. But I still prefer breast conserving surgery with radiotherapy. And conservative mastectomy for me as a surgeon is, let's say, a backup option if breast conservation is not possible.
So always the first option would be breast conservation?
Yes, always. Anytime it's possible, even extreme oncoplastic surgery, yes.
Yeah. One last question?
Thank you for the nice presentation, Dr. Catanuto. We were speaking earlier in the other room about the recurrence after conservation. So I think it's now time to discuss the recurrence after conservative mastectomies. I had a case discussing with me 2 weeks ago. She had the first case for me to see local recurrence after skin sparing mastectomy, and she was speaking why not to remove this recurrence and preserve the whole envelope and the other the reconstructive methods. So I'd like to know, how do you deal with cases with local recurrence after conservative mastectomy?
Well, this is a very interesting question, and I think that by the time we are increasing the number of cases we are doing with conservative mastectomies, we'll see even more local recurrences like in breast conservation. Well, we haven't got data, obviously. We haven't got data from robust data, but even very few observational data on this. And I will probably manage it with a further excision and radiotherapy in the recurrence setting.
So you will not abort the reconstructive method. You will keep the
Yes, I will keep the reconstruction. Yes, of course. Yes, yes. It depends. Obviously, it depends on clinical examination. I mean, on clinical data, on what you see, on what kind of recurrence you have. Sometimes it could be very difficult, for instance, to if you have a recurrence in the lipopleural complex, obviously, You may change the technique for reconstruction if that's been done on autologous flap, on implant based. You can change the technique, use an autologous flap, because it will be very difficult to reconstruct the nipple areola complex after an excision, after a conservative mastectomy.
Would you advise for an MRI to assess any residual breast tissue?
Not anytime, not anytime, because well, it really depends on your surgical techniques. If you are, if it is clear that you performed a very good mastectomy, and once again, I recommend, and I'll show you later in my next presentation, the video, the mastectomy should be a proper mastectomy, and not conservative in terms of leaving fat behind, leaving very, very thick flaps. Doesn't make any sense. There was another presentation in the other room from Laszlo Tabar showing clearly that Cooper's ligaments are containing breast tissue. So if you leave a very thick flap in a very adipose breast and you are leaving, you are leaving a certain amount of breast tissue behind. If the mastectomy is done properly, I don't follow my patient regularly with MRI, but otherwise it could be helpful in new cases not performed by my team, by my unit, where there is any doubt. You want to see, you can also perform sometimes also mammogram. Sometimes it's very thick, the flap.
Thank you very much.
Thank you.
Now